Thank you to the Echo Group, TB Echo Group, for having me today. I'm very excited to be here. Even though I'm going to be sharing, our experience, my experience, and also our laboratory experience here. I will also be learning a lot from you guys as well. Like you mentioned, we'll hold the questions at the end, and will be some interactive conversation or discussions. With that, I'm gonna share my screen. Let me see. All right, here. There we go. Can you all see my screen well?
That looks wonderful.
Okay, awesome. Yeah, we just, went over the technical issues. All right, so yeah, just like Dr. Lippman, Soren Lippman mentioned that, yeah, we're gonna be discussing about, MTB, utilizing MTB in the clinical setting. So this is my disclosures. I'm a part of, a speaker bureau of with Cepheid. Um, and these are the objectives outlines, as you probably already read through the outline. So mostly focusing on the, laboratory workflow for mycobacteria testing. And, also like you also learn from like our different, workflow wise, but typical workflow that, we're using in a clinical laboratory setting and utilize MTBR, GenExpert, MTB PCR, and then of course, their methodology, algorithm, and any like challenges in for our test interpretation. I know you all are all familiar with the, MTB complex, disease, transmission and disease and epidemiology. What I want to draw attention on this slide is that it takes really only such a small dose of organisms to infect. So keep in mind that the infectious dose is really low. That makes it really dangerous in TB, spreading, and that makes public health risk, at a really on the top, level in the top tier level of the high risk pathogen. And I know most of you, or if not all of you, or some of you are, involved in the infection prevention and control measurement. And because of this high risk and the high cost, I don't even have to mention that, all the stigma, everything associated with the MTB complex and, infection prevention and control. And anytime you are already experiencing that, anytime you are, have a high suspect TB patient, and in order to rule in, rule out from airborne isolation, I just say, AII, airborne isolation, infection isolation, AII, in order to remove that, and you really need a confirmed, laboratory confirmed diagnosis. So this is where the lab comes in, because clinicians and, in the IP and epidemiology, epi and epi team, and, everybody relies on the lab results for AII removal, and the lab plays a really crucial role in giving a really diagnosis for TB. So how's the laboratory workflow and, and behind the scene workflow for, our MTB diagnosis? When we mention MTB, AFP, SFR specialized. So SFR specialized, the big, this is, what in the laboratories atmosphere calls it, AFP smear and culture. Every time you order, as a clinician, if you order culture, depending on how the lab, menu is set up, AFP culture, smear is not mentioned easily, but keep in mind that AFP smear and culture, they are always together, right? So for AFP specimens, we all know that we're dealing with the, most of the specimens, coming from respiratory. We're dealing with a lot of respiratory specimens, and majority coming from sputum, the bulk of the specimen sputum. So this is also this respiratory portion is also the part that we're really be really cautious about, for especially for the airborne isolation, infection isolation. And so this is a breakdown of, general AFV specimen that, diagnosis that TB diagnosis that clinical labs receive. So, and then non-respiratory portion. There's also cases that you are all familiar with the extrapulmonary TB. So extrapulmonary TB as well, so sterile or non-sterile. So and then breaking down into all different different categories. So why do we break it down? So that really depend the type of the specimen, nature of the specimen, that dictates the how we process the specimen for optimal, really optimal yield for especially for mycobacteria and then tuberculosis, and especially for TB, and obviously any mycobacteria. If the I know we're not in the and as the United States overall compared to other part of the world is is not TB prevalent endemic, but we're also looking out for other non-tuberculous mycobacteria, so any pathogens, and obviously concerning TB. So the recovery of the pathogens, it dependent on how we classify the sample, how we process the specimen. So many of you are already familiar with that. If you aren't, or in, any medical students, or if you're joining in, and if you're not familiar with the workflow, and also please visit your your neighbor labs, in your institution's laboratory for like how the TB lab is set up. So we is required TB processing, TB diagnosis, the entire TB workup. The mycobacteriology workup is required to do it in BSL-3 setting. Most labs in BSL-2, so they call it BSL-2 plus, BSL-2 with the BSL-3 practice. So either BSL-2 plus or BSL-3 standard requirement, BSL-3. And you have to have a containment and a PPE, and also obviously working in the biosafety cabinet at all times. So as I mentioned earlier, the specimen breakdown, the type of specimen, how we handle the specimens really dictates the recovery. So we break it down into, generally break it down into sterile and non-sterile specimens. So for sterile specimens, we don't really need to do a whole lot. It's just pretty much, those something like, CSF or, deep, invasive, sterile body fluids or tissues. Either you just, grind the tissues, or if it were, sterile body fluids, and then you centrifuge the fluid and using the concentrated specimen for staining, inoculation, and you do the, the rest of the culture process. Versus non-sterile, so this is where, the important part, about the bulk of the specimens that we receive daily is they are from sputum. The sputum, this part is really important, because the sputum is the majority of specimen, and as you all know, that the sputum is really yucky, and the really is a quality sputum specimen is thick, mucousy specimen. So in order to extract, have an optimal recovery of the specimen, of the recovery of the pathogen from sputum, it has to go through a series of process. So first we have to break down the mucin. So that's why we use the NALPAC, NaOH, the digestion decontamination reagent, and as in easy term. So you have to break it down, and then you also imagine, sputum respiratory tract specimen also contaminated with the normal oral flora. So you also want to get rid of the normal oral flora, because if you have the normal oral flora, they grow, like strep anginosus, or strep, any kind of strep, or any kind of normal bacteria can't overgrow if there's TB present, if there's slow growing MAC, or anything present, a pathogen present, they're gonna overgrow it. So we don't want that happen. And we also know that MTB grows, right? It is a slow grower. So we have to get rid of the normal flora. So this part is really important. And there's certain chemical percentage. So pretty much decontamination as we do it, we do it by alkalinization. So we pretty much kill off by alkali, and then you neutralize it, and you do, and then and then the digested and decontaminated liquid or the specimen is then subjected to the centrifugation at the end, and you get a really concentrated specimen. So you end up with a little pellet here. So that little pellet is what you use to do the primary specimen. This is what we call AFP smear, and then you also use that for to inoculate it into liquid and the solid culture. It's a little stuck here. Okay, so this is another way of presenting here. So we have the digestion and decontamination process, especially for the sputum and then and the non-sterile specimen sources. I was given an example sputum as an example. But non-sterile, the sterile specimens, you can, we just pretty much go into this, get to that stage, and actually the arrow should come from here. So inoculating into the liquid and the solid media, and then when it grows, and you also wanna make sure that the growth, because it is a long process. You also want to make sure that whatever grow is, there is some kind of AFP, acid phos bacilli, or some kind of mycobacterium acid phos bacilli, right? Acid phos organisms. So we want to make sure that these are acid phos bacilli. So before even we go down to the rabbit hole, so you have to make sure that these it is AFP stain positive either by Kenyan. We're gonna go into the stain in the next slide, either by Kenyan or Zeal-Nielsen stain. And then once it's confirmed, and then you use that specimen to do additional identification, whatever kind of method that you use. Currently is a MALDI is the latest and mainstream methodology. Before we used to do probe-based testing. So this is essentially the workflow. And then I mentioned the AFP stain, right? So AFP stain, what we use, what the laboratories use, there are two types of stain: fluorescent stain versus a carbon fusion based stain. So fluorescent stain has an Oramin O component that binds, and it has the Oramin, or in some labs you also utilize rhodamin. So essentially it binds a mycolic acid, and the rhodamin has a little contrasty orange color. So some of they use they add they use Oramin rhodamin combo. Some just use Oramin O, but so that's really specific for AFP, because acid phos bacilli, mycobacteria, they have highly rich mycolic acid cell wall, so that's what it binds. Carbon fusion based stain is also the same principle. So fusion from the primary stain also binds to the mycolic acid, so it makes a really complex into the cell wall. And then some of you know that there are two different types of carbon fusion phase staining. One is Zeal-Nielsen stain. So if you have to for medical students or any students, if you have to remember for your boards, you just remember like hot and cold stain. So hot is Zeal-Nielsen stain. You just you use heat to drive the stain into the cell wall, and the rest is you use the counter stain. And then for the cold stain is Kenyan stain. Kenyan stain is essentially you just using phenol component to drive the stain. So and also because it is a little bit weak, so you don't also want to decolorize it too much. Then you want to use a weak acid decolorizer when you are decolorizing it. So hot versus cold. And then reporting wise, from the primary specimen. So you're staining, if you're staining from the primary specimen, reporting, it is semi-quantitative reporting. So you clinicians are already familiar with the, from your primary specimen, either 1+, fluorescent staining positive, or 2+, 3+, etc. And how do we use it? How at what stage do we use it? Like which stain which stain do we use in what stage? So in general, this is most labs use the direct clinical specimen. They use the fluorescent stain for the direct clinical specimen. So, after, remember the digestion and the decontamination process. For after the processing phase, and then they use we use the fluorescent staining, and then confirm either you confirm it by the carbon fusion staining, either Kenya or Zealand stain, or some lab just directly use the fluorescent stain and just report it out. And the primary use of this, it can carbon fusion based stain here. Not a lot of labs. I'm not quite familiar with if any labs only primarily using the carbon fusion based staining for the primary specimen. However, it is really utilized well in the positive culture, either solid or liquid, culture positive situations. Remember when we have the positive, culture positive growth here. So when we confirm that by the Kenyan stain, and this is really quick and also fast as well. You don't need to have fluorescent scope set in, and you just quickly stain it and take a look at it. The reason I'm mentioning why under which setting which stain is utilized, and then the reason that I'm not familiar with this, the carbon fusion phase staining in the primary specimen is that because of the sensitivity of the stain. So this is actually a seminal article. This was published like over a decade ago, but it has still been a great article. So this was a survey from the proficiency testing from so in laboratories we have to enroll in the proficiency testing to make sure our testing is correct and accrediting, it got reported to accreditation agencies. And so that's is from the study from that group. Max Zolfinger, he well known AFP microbacteriologist in the nation and then worldwide. So they did a study and looking at like the different staining and sensitivity and specificity wise. So here is a quick quick and dirty comparison: Zeolnist and the hot stain versus cold stain. And Zeolnist and really outperforms Kenyan staining. But then when they compare the fusion based staining, regardless of Zeolnist and or Kenyan stain, and against the fluorochrome fluorescent staining, fluorescent stain outperforms by here, as you can see, that the number of bacilli that they can see with a number of microscope field. For example, here, even to see a 1+ bacilli, you only need to do 10 fields to you see a good amount. And at this low power versus you have to have 100 fields to get through 100 fields to get the same number of bacilli with the fusion state. So this is how sensitive it is. So compare the fluorescent stain is more as sensitive it is compared to the fusion stain. So which is why it is generally utilized in for the primary specimen. So the primary specimen meaning the specimen really before it's it gets culture out, right? So we know about the staining, and so the staining and smear, the microscopy, it comes also with the sensitivity, right? So how exactly, like how sensitive it is, right? What level of organism that it can that we can detect in the microscopy, right? So this is just based on the most sensitive stain, the fluorescent stain. We know it is the most sensitive. So this is based on a number of literature, based on the number of literature and various studies, the average, organism that you would need, about 10,000 or between 7,800 to 10,000 CFU. You need this many, organisms to be able to visualize on your smear, on the smear. This is even with the direct microscopy. And I know, I think Lena mentioned it in the beginning about the interactive, testing. Sometimes I will, when I give a lecture, AFB lecture to my residents, I would call out, hey, how is it compared to NAD testing? Can you just give a number, or can you just give like how many times it is like more sensitive, or how many times more sensitive compared to the fluorescent staining? I don't know if anyone can guess. Uh,
I know a lot of folks are on today.
yeah, the magic number here. So this I'm only putting out here this expert MTV as the limiter detection here because this is the only FDA approved testing in the market and out here in the US here. And I think I used to put another company. I think it was Roche that was about 200 something CFUs, but that's also not available in the market anymore. So I just leave this one here. So as you can see, so there's the NAT PCR-based testing is about 20 times, 25 times more sensitive with the NAT. So where does it come in? So how do we put that in testing? How do we put NAT in our testing workflow? So remember, so we have the specimen, sputum, digested and decontaminated the sputum, right? So at the end of the process, so that we end up with the pellet here. So this is where it comes in NAT, and also keep in mind that it is only FDA approved for sputum specimen. So this is only what we're talking about today. And so this is even though I put it BL here, this is not related to BL testing. But then so this is where NAT comes in play, and then or if you don't have enough specimen, we don't have enough specimen to begin with. Sometimes, depending on the sputum volume, then sometimes we won't have enough even to do the whole process, and then sometimes you have to do the direct sputum. I'm sorry. Student on NAT. And in that case, their package insert also mentioned, their sensitivity is a little bit lower. I would say it's a little bit worse than the concentrated sputum sample. But in general, it's comparable. So this is where we utilize it. And then even though I put it out here, like, so what kind of NAT testing is available on the market? Not so much. This is the only thing that we have right now in the US. I know I have I put in a lot. It's really salivating, right? It's really appetizing. There's the TB lamb and it's I don't know if some of them used to be on the market, but there's no more anymore. And this one here, genotype and MDBDR. So this one is really interesting because you can also do this is also multiplex PCR. It's not just MTB. I think it also has a NTM and also the drug resistant panel as well. You can also do it from the isolate, and this one is only research use only. Some reference lab they were able, they are still able to acquire. I think maybe at one giant reference lab in the nation they were able to acquire the research use only product, but it's not available in the market. So the only available FDA approved available in the market is the MTBRF assay here. So how does it perform? How's the performance here of NAT? So this is a study from I put it out here because it's really interesting. It's a study from Africa. They did it. That was actually already a decade ago, almost over a decade ago. They did it. They did the MTB the expert MTB PCR on all different samples, but we're gonna focus on the expert, the sputum, like two different sputum sample types. So as you can see, even between the expectorated and induced sputum, the positive samples, the CT value is much lower for expectorated than much lower than the induced sputum, and also this group, and when it turns the liquid culture, the midget liquid culture, when it comes positive, the number of days to turn positive is also much quicker with the expectorated sputum than the induced sputum, and also correlates really well with these two types of sputum is that when you have the expert positive expert TB positive specimen, though those cultures, their accompanying cultures, they turn positive much quicker. So the average is like maybe I would say between a little over a week or a week time frame versus those actually the the dark circles are the positive samples, MTB PCR positive sample versus the open circles are the negative samples. And so in general, so MTB, if you have MTB PCR positive, so your the time to positivity for your culture also is quicker. But eventually, we're still using, we're still having PCR the culture as a ghost, and we still have to have culture grow out the organism. And again, another study, comparing the number of smears versus the number of experts and comparing the sensitivity and specificity. This study they did it right around when right around when the expert TB came out on the market, and so this is from a group from North Carolina. They're really nice in a way that they break it down into like AFP smear positive group and the negative group, even though the number is small, but the takeaway is that the 2 smear versus 3 smear, the sensitivity, and then the positive PPV and NPV, positive predictive value and negative predictive value, and when compared to the expert, the number of expert testing, if you're only relying on the the smear, even with 2 smear, your PPV and even your sensitivity is really low compared to the 1 expert versus 2 expert. This is in the smear positive situation versus in smear negative situation, the experts will still pick it up, but the sensitivity is slightly a little bit lower, but the smear, the PPV and the sensitivity it really suffers. So so this is showing you the smear versus expert for how it how NAT outperforms, and then it's followed by the same thing again. This is a quick summary from by really seminal review article from Journal of Clinical Microbiology about comparing the between the 2 tests, but we don't have this one, the Hologic MTD test on the market anymore. So Cepheid Expert Expert test is the only available right now. So the smear sensitivity in the AFP smear negative specimen versus positive specimen, if you have more than 1 specimen in the AFP smear positive, your sensitivity is higher, your positive prevalent PPV is also higher. So the takeaway is that you have higher PPV, especially with more than 1 specimen. Your PPV also is higher also in the smear negative specimen, but it's not as high as AFP smear positive group. And specificity also, specificity is kind of similar in a way, so you can pretty much utilize it. But also, it is recommended that your negative predictive value is much higher if you have more than 1 specimen. So keeping that in mind, so you really need more than 1 specimen to increase your PPV, increase your especially when you're ruling out from the airborne isolation. Using the expert for airborne isolation, you need more than 1 specimen to increase your value. So so keeping that in mind, you wanna put that into perspective in your workflow consideration. Do you want to use it? You want to use your PCR in the smear positive cases, or smear positive samples only, or smear negative, or do you want to use it only concentrated sediments versus like any kind of any sputum use? Doesn't matter if it's a direct sputum or concentrated. So this is actually the workflow. Like there are a couple of different workflow, and I'm gonna also share you my experience here. So this is the current workflow that we have set up right now. So and most laboratories as well. And when I in my fellowship, when I did my the clinical micro fellowship, so this is also what we accept. We only accept MTB PCR with the AFP smear and culture together. So you have to have a combo set, and you have to have at least 2 PCR within the order set, or depending on the setting, sometimes 3 combo sets. There's another a different workflow strategy, and this is reflex algorithm. I'm gonna have to tell you this workflow is you run Expert MTB only on the smear positive specimen. So you have your AFB culture smear, you do the smear positive, but then only when you smear positive and then you run it. So this workflow some laboratories utilize. I'm not sure if how how widely a lot of people are practicing, but this one here I have to tell you that we used to do it in the past. I'm gonna also have to share you that story in the later part of our talk. So using knowing that MTB PCR the sensitivity and specificity and the number of specimen that you use for ruling in and ruling out, and in conjunction with the AFB smear, which is really helpful, especially also in the NTM infections, right? It's not just TB as well. So especially in the this article highlights the smear positive, MTB PCR negative cases in at least helping predict the NTM infection. So really, though, this group here has this sensitivity specificity is for the diagnosis of NTM. So they have a higher sensitivity. Sensitivity in the high 80s for predicting the NTM infection, especially when you have the smear positive and then PCR negative. So knowing all that all those factors in play, right? Smear positivity and then the TB MTB PCR component. So how do you put that all into perspective for interpretation, right? So this is the CDC recommendation. It's the same, also the same article, the review article that is a lot of labs, including us, we also use it as a when we put together SOP and guidelines for. But that's so when you have an AFB smear positive and then the TB net is positive, it's definitely is a presume pulmonary TB, and and we all know the smear sensitivity is not that great. So there's situation the smear is negative, but TB net is positive. So this in that case, you really wanna also wanna perform a second specimen as well, and then confirm and also obviously in conjunction with the clinical presentations. But at least high on the TB, this is TB presumptive positive. And this part here is really interesting. When you have smear also negative, TB is also, the net is also negative. This really help in ruling out, especially for airborne isolation. It will support the isolation if it's, if you also have a supporting, clinical judgment as well. And then you can also, depending on the clinical symptoms, you can either continue the TB treatment. I leave it up to you, up to the clinical teams, but then this is really helpful in the airborne isolation. Versus this scenario here, we mentioned, smear positive and the net negative. And it's also, you also need to have a second specimen or, a subsequent specimen to confirm that, hey, at least, you can at least rule out, this may be indicating NTM as NTM. And so this is really also helpful in the airborne AII removal as well. So we mentioned the AII removal. So some as you are already aware of the standard guidelines, you need to have 3 good spurums and you need to have 3 consecutive negative smears, AFB smears, in order to remove from the isolation. This has been the standard practice, a lot of our practice. Also keep in mind that for 3 good spurums specimen, we really need at least 1 sample has to be the first morning sputum sample, because it has really like deep, really concentrated overnight, and then it has to be at least 8 hours apart. So the smear-based, airborne isolation, this has been the practice since, early 2010. However, the guidelines updated, as we all know, the smear microscopy-based, sensitivity is not that great. The average is 50-60% sensitivity compared to the net testing. And you also using kosher as a gold standard. So based on that, and based on that factor, and the performance of our net. And in 2016, the APHL did a updated guideline for using the 2 consecutive negative expert as airborne isolation removal. And then in 2020, in the WHO, and implemented as NAT as a standard of care in practice. Again, keep in mind this is not a replacement for routine AFB coaches. Still a gold standard, because there can be still cases that the number, the organism bacterial load is low enough that it doesn't get picked up by the PCR assay, and then you can still grow it out on the culture. So, and also in the laboratory, environments, we are, a lot of labs, not sure about the, Washington Department of Health, a lot of labs, even including us, in New York City, we're a lot of subjected to the, accreditation agency, and so College of American Pathologists (CAP) also implemented a guideline that was in 2020. And this is only phase 1. It's kind of like very lenient. It's not really like strict, but as still, it requires laboratory to have a rapid detection by a rapid detection of MTB, so by NAT testing. Even if the lab doesn't perform it, we have to make sure the lab has to make sure that the clinicians have access to the rapid NAT test for either by sending out the reference lab or any lab in the neighborhood, or even in the by the Department of Health. So that's really really helpful in the saving strategy as well, the using expert. And as I don't have to stress too much that the using smear versus expert in the isolation room, the time due, because the isolation room that there's in the hospitals are really limited in the number of rooms, right? The ability to really like rapidly, get it moving, rapidly get the patient out of isolation if it's the laboratory confirmed negative is really important. So isolation room cost is really saving is really huge, even though expert is more expensive than the smear. But so which one do you want to use as a organize, if you're thinking about a whole organization, like you want to the per test testing cost is much do you want to suffer in the cost versus you want to suffer in like a big cost saving, and then also that also helps with the patient as well, right? So as you can see, the a big difference compared to the diagnosis differences versus the isolation room and overall cost. And yes.
I apologize to interrupt. I'm just doing a time check. It's 1:17, and I know many of us are interested in some of the potential challenges, including false positives and negatives, and also leave time for Q&A. So
okay,
it's appropriate to go to this.
Yes. So let's quickly just go through that. So we all know the processing time is much. Thanks for the reminder. Much faster. AI duration is faster. So you're already familiar with the the APHL workflow, right? So having the multiple samples is really helpful. So if you have the positives, it's pretty much good. If you have the negatives on the first sample, is you just want to keep on going with the second specimen, and then for the AII removal, right? Actually, I'm gonna just quickly just I know we wanna just get through I'm gonna just skip pretty much like our lab experiences that we used to do the reflex algorithm, and then now we're doing the the combo requirement, the combo setting, which is really helpful. And I know I have data, so not enough time to mention it, but really the highlight is this is the data from before we made changes, and this is really highlighting the importance that we're in the smear negative, culture negative, that where we didn't perform MTB from the PCR, and that this number of patients could have been removed from the airborne isolation. So So with that, getting into the really meat of the talk is that, hey, no test is 100% perfect, right? So we're experiencing, like Laura loves, has some experience with like challenges. There's some challenges with expert and either false positive versus false negative, right? So whether you have MTB component only, remember MTB RIF, PCR testing, MTB component, and then the RIF, the rifampin resistant testing, rifampin resistant component. So whether you have MTB false positive only, but your culture didn't grow, so this is really indicating false positive MTB. Versus you have, yes, we have MTB, culture also grow, but the assay calls out, rifampin resistant. Then this is false rifampin resistant. So that different scenario. We're gonna go through that. So this is the algorithm, testing algorithm by the instrument software, right? So the instruments is what the assay detects. The assay design is that, hey, it detects this the specific region of the RPOB gene. That's also for the rifampin resistant determining region, right? So this region here. So the assay has 5 probes. So essentially, all these 5 probes will bind, when TB is present, and if there's a difference in the CT value, if there's TB present, there's CT value less than 2, and that's when you will get a positive value. So see here I have a demo picture here on the right. Is this is a control, and then between the different probes, so you have to have a delta CT is less than 2, and then it will call out as MTB. But in order to call out RIF resistant, you have to have a 1 probe dropout, right? Because the one of the probes cannot bind because there's a mutation in this region. So usually the probe B is usually the indicator. It will be the one to drop out, and then and when there's a probe drop out, and then you will have a difference. So this I have an example here. You have a drop out of the 1 probe, and that gives the delta CT value will be greater than 4, or delta CT value that either with the 1 dropout probe and any of the probe, it has to have a greater than 4. So this one here. So you see, this is a control, and this one is a probe B dropout here. So there's a delta difference. So that is how the assay is designed. But of course, we're going to talk about, what are the false positive, what are the situation, right? So number one situation is, in patients who already established TB established patient who maybe already have treated with, already successfully treated or partially treated, 6 months, or, some kind of defined time frame, and then somehow the patient get, TB PCR, and a situation that, TB didn't grow. So this instance, I don't have the pictorial example here. This instant, it could represent positive DNA. So positive DNA only, but there's no live bacteria. However, there's also a situation that the prevalent TB prevalence is not that high in the even though to give you an example in my set in our lab setting here is, yes, we're in the thick of the in the Bronx, and we see really diverse TB patients as well, but still we're seeing NTM much higher. So NTM positive patient population much higher. So NTM prevalence much higher. So depending on the specimen, the patient with a high burden on NTM. So there have been, some literatures already reported that, some of these organisms have some sequence, really, highly closely related to the target region that the assay targets. So in that case, somehow there's some competition because so many targets in the reaction happening that it's really outcompeting, and it's really causing a dropout in the probe. And this is actually an example here. This is a NTM patient with really high NTM case, but it's also calling out MTB. It also is calling out RIF resistant as well. But what is abnormal here is that, as you see, there's a number of our probes are really dropping out here. So keep that in mind. I'm gonna come back to the how do we get this resolution, right? So this is really not abnormal, because it typically when you have a MTB detected, and then if you also have a RIF resistant detected, you really want to have, you won't always see so many probes drop out. So this is one situation. That's where you see the false, not just MTB detected, and also RIF resistance detected. So it is really competing the probes. Another situation, this is actually a case, TB positive patient. Actually, this is this patient actually a low level TB. But some reason there's some kind of like a delay binding to the probe, but then you see the amplification here. This is really not not a good amplification, and also there's a probe in ER dropping out, and also calling false rifampin resistant as well. And another situation is really squiggly, but it's also calling out both TB positive and also RIF positive as well. So these two apparently, when there's a what happened is a low level organism, but this causing a delay binding and causing a delay dropout, and but because of the algorithm is and there's here, as you can see, when the delta difference is really high, that's why it was calling out for RIF resistant as well. And then another example here is this one here is a TB, a true TB positive patient, but it's also calling out the RIF resistant. For TB positive, yes, it is the TB positive, but it's really interesting that how the probe, the CT value readout, there's no dropout. However, on the graph itself here, there's a flat line here. So that is probe B that is dropping out. Based on that, we just don't know what happened with the algorithm. It called out rifampin resistant because of the this probe B dropout. Even though all the CTs are, they are all amplifying nicely. But in this case, actually here is a silent mutation. When you look at it, because it is still amplifying in the probe B, which is the most common, dropout of rifampin resistant. When you have a rifampin resistant, the probe B is usually the one that's usually drop out. But in this here silent mutation, the silent mutation is also the most common mutation. Is still responsive. It should still be responsive to the RIF rifampin, because there's only like one amino acid. There's only one mutation, one codon difference, but there's no changes in amino acid. But probe is not binding, and it's causing the false positive resistant. And then the next situation is the flip, right? The flip is we're getting a false negative. So this is a true TB patient, but a TB patient, but this one also doesn't pick up the RIF resistant at all. This is given out, just normal, rifampin. RIF resistance is not detected, and the graph, the amplifications is really amplifying nicely. The controls and all the probes are amplifying nicely. But what happens to this is that when it turns out, and when you confirm the isolate, the genotypic feature, and when they send it out to this patient, isolate, when they send it out for drug susceptibility testing, it turns out it's rifampin resistant. So this then when they sequence it, in this case, when they were sequenced, the isolate was the RPOB sequence, and the mutation is outside the rifampin resistant determinant region. So remember the assay design, how it amplifies is, is within the primer binds the RRDR region, and it amplifies. So if the mutation happens, it's outside. When it happens outside it won't bind it. So but you are getting the false resistant. it is there, but it's not as common. It's not as common. But I'm not sure how many cases like in Washington that you guys see that outside the RDR cases. So and then what about what about false negative like MTB detection cases? What about those cases? So there are situations that I alluded earlier that there's low MTB burden when it's even below the limit of detection that but the culture eventually grew. So in those cases, and it can also give you a false negative. Apparently, sampling errors that can be applied. You can apply it to also the false positive situation as well. Sometimes depending on how the samples across, are contaminated and giving a false positive or false negative. So how can we remediate that? So you really want to have putting in the a big overview like a pre-analytical analytical mindset, and look at the pre-analytical error. So is there any cross contamination, right, when you're processing the samples, and also is a correct patient specimen, right? So that's the first thing first, and then get into the testing, the test result. And as you already saw, the normal amplification, the MTB in the normal cases, you want to really see the nice amplification like curves, sigmoidal. So that should be your sniff test, right? Any positive test, it should be your sniff test. You should also have like a CT value. You should also look at the CT value. All the probes should have usually in the 20s or in the late 20s, or maybe if not in the early 30s. It's all the probes should have a really nice CT value. So you really want to review the amplification curves and CT values, and also the how many probes that got detected. That's really important because I already showed you from the examples of the false positive cases. There's so many probes are dropped out, so that's not normal. You don't see a lot of probes got dropped out in in the positive cases. Even for right membrane resistant RIF resistant case, you will see mostly probe B probe is the one that drop out. You don't see it so many probes drop out. So those should be your in your consideration when you it should be in your review. And obviously the smear should be also a part of your workflow, and you want to review the smear, how is a smear positive, and if with your smear positive, but your not the PCR negative, or also the culture final culture result as well. And apparently, patient TB history, something like the already treated, and then when they also get the NET testing again for some reason, so they may not have a viable organism, but that the assay is picking up the that bacteria and the DNA, so that is just possible. So you really also want to know the history, and so recommendation is always obviously repeat the testing, and then again if the amplification is pattern is still persists, you have to review that, and obviously phenotypic testing, if it's MTB, and also drug susceptibility testing, phenotypic testing as well, any potential clerical error. And if all the phenotypic testing it doesn't resolve, and you also might wanna sequence RPOB gene as well, because in the silent mutation, as I mentioned, right? So it can happen. Silent mutation, that's the most common, and the mutation outside of RDR that gives you a false negative. So CDC recommendation is that anytime you have RIF resistant detected, you really want to confirm with the sequence-based testing. You also want to confirm with the DST, the phenotypic drug susceptibility testing, and you obviously want to have a clear communication with IDs, and hey, constant communication. Hey, this is what we're finding out, and it's also really important for our patient care as well, because or the any step of the investigation that you really want to have a clear communication. So I hope this really summarizes the about the expert MTB testing, and then their graph interpretation, and the result interpretation, and whatnot. So with that, yeah, I'll take any questions.